So my presentation today is on ECMO and survival. And so I wanted to read this first. Let me put this up, this next slide. So William Barnett was a night watchman at the Chelsea College of Science and Technology in London. On the morning of January 1st, 1965, he and two colleagues had tea. Quite a British thing to do. 20 minutes later, they started vomiting. They drove to the nearby hospital, where they were seen by a nurse. The nurse spoke to a doctor on the telephone, who advised the men to go home and call in their own doctors. That sounds like a sensible thing to do. They left the hospital. A few hours later, Barnett was rushed to the hospital and died from arsenic poisoning. His widow sued the hospital for negligence. The court found that the doctor failed in his duty of care. He should have examined the patient. Yet the claim failed because it could not be shown that Barnett would have survived even with proper care. The doctor may have been ethically culpable, but to establish negligence in the law, the widow had to prove on the balance of probabilities that the doctor's breach of duty caused her husband's death. In medicine, blah, blah, blah. Basically, the patient was going to die anyway. So where am I going with this? Well, the patient would have lived anyway. The better your outcomes are with ECMO, the criticism will always be the patient probably really didn't even need ECMO. But the longer you wait to decide, the poorer your outcomes will be. And the criticism will be, this patient was going to die anyway. What did you do this for? So you're damned if you do, and you're damned if you don't. That's, I think, the paradox. That's sort of the direction that I'm going with this presentation. So ECMO is indicated for cardiac support, VA only, is indicated for cardiogenic shock with severe cardiac failure due to almost any cause. So you can look at this list and see acute coronary syndrome, refractory arrhythmias, lethal arrhythmias, sepsis with profound cardiac depression, drug overdose, pulmonary embolism, acute anaphylaxis. So any reason that you have circulatory collapse, ECMO is clearly indicated. Now, outcomes are a different story, but we'll get into that a little further. Post-cardiotomy syndrome, vis-a-vis you can't wean the patient off of cardiopulmonary bypass. Post-heart transplant, in other words, the graft failed. And chronic cardiomyopathy as a bridge to either a VAD or as a bridge to decision. Now, that can turn into a bridge to nowhere, but it can also turn into a bridge to anywhere. So there's a lot of variability in all of this. Peri-procedural support for high-risk PCA or PCI. I guess now they're using Impella for that, but Impella costs $25,000 to $30,000 for a catheter when you can put somebody on ECMO for $1,000 or less.
Or a balloon pump.
Or even a balloon pump, even cheaper. But the balloon pump doesn't offer you quite the same support. In other words, and that's a really good question. So if you're going to do VA, you have to have the oxygenator obviously in line. Now, if you want to go through the atrium and do like a left atrial to femoral artery, you don't have to have you can have the oxygenator there in case you need it, but you can omit the oxygenator from the circuit for surface area if you wanted to. It'd be a little exotic, but you could do it. But VA ECMO for a high-risk PCI or for TAVR support or something like that versus an Impella, I think is really a much more economical and possibly even a more technically simple approach towards what is a relatively common problem. And even you can keep them on it long term should you need to. You just have to make sure you have good lungs. But the same thing applies with the Impella. If you use the Impella for a high-risk PCI and they fail and they go into RV failure, you really need VA ECMO. The Impella is not going to help you. You got to throw in an RP, and those aren't so easy to put in.
I don't know that they're commonly used enough for the practice.
Yeah, I question that too. I think that we'll have to wait and see what happens with that. Okay, so moving on. Indications for respiratory support. Severe bacterial or viral pneumonia. Okay, that's very common. We see that a lot. Aspiration pneumonias or aspiration syndromes, alveolar proteinosis, extracorporeal assistance to rest the lungs for airway obstruction, pulmonary contusion, a fireman gets smoke inhalation or a victim, lung transplant if you have graft failure or the graft just isn't quite strong enough at the moment, bridge to transplant, and that's very common. In fact, they talk about moving patients, taking patients and walking them down the hall of ECMO. And everybody thinks that, well, patients on ECMO, why can't you move this patient down the hall? Well, there's a big difference between a patient who is on VV ECMO awaiting transplant versus that has had a chronic problem versus a patient who is septic, sicker than dog do. You're not walking that patient anywhere. They're probably going to have neuromuscular blockades on anyway. So there's a big problem, big difference in the type of patient that we're talking about. But I've had a lot of people say, why can't we wake this patient up and extubate them on ECMO?
No, we do. We see that frequently. We're seeing that more and more, especially on VA. But the problem with ambulation is, for pulmonary support, absolutely. But you can use it's all about cannulation. That's your first step.
Yes.
In VA, more than likely, it's going to be femoral cannulation or two different insertion sites.
And you're not ambulating somebody who's femorally cannulated.
At best, you can sit them up.
And you and for VA, sometimes that's what you have to do if you're not centrally cannulated. But, for VV, I don't like femoral cannulation. I just don't think it makes sense. But I know you and I disagree a little bit on that.
Completely.
We can have that discussion moving forward. Anyway, and also, of course, for pulmonary hemorrhage with hemoptysis and for diaphragmatic hernia and meconium aspiration, probably the most common reason we see it in the pediatric world anymore. Absolute contraindications. Among these, futile treatment without an exit strategy in cases of, and there's the list, especially brain injury, malignancies, unwitnessed cardiac arrest. Those are very concerning, especially when they do end up on ECMO. Unrepaired aortic dissection, prolonged CPR, AI, big problem because the heart's probably so dilated and damaged and put them on VA ECMO, it just blows it up and that's it. Or clots later on or whatever the case may be. Compliance, in other words, is this patient going to be, if they're homeless and you bring them in and you save them, we're all here to save lives, but is this patient going to be compliant? How far do we go? A big difference between a 17-year-old that drops on the field because they have IHSS or a bicuspid aortic valve versus a 55-year-old homeless person, or even a 55-year-old who was out his morning jog before he went to work versus that homeless person. I mean, we do have to be, and I'll talk about that some moving forward too. VV ECMO is contraindicated in cardiogenic failure and in severe chronic pulmonary hypertension, and relative contraindications are for anticoagulation, advanced age, and morbid obesity. So, my talk could end actually on this slide, but it won't. Survival rates reported in the literature range, and this is for VA, between 20 and 30% among patients who receive VA ECMO for these common reasons. That was validated and by Shin later on and for looking at discharge times and 30-day and 1-year survival. He says that ECMO performed for cardiac arrest was associated with increased survival with minimal neurologic impairment compared to conventional cardiopulmonary resuscitation. So patients who did receive ECMO as part of their resuscitation versus those who survived the resuscitative event without ECMO, the neurologic outcomes were better. I think that is important because it is all about circulation. Right. And you can do some great CPR, but it just doesn't. That's, I think, why prolonged CPR is in there. You can do great CPR, but it is never going to compare to the circulatory support you can give with a mechanical device. But are these the 20%? This is a quick video. Can they hear it?
Buddy, and I saw that everything was ordered. So they were like, "Oh, go ahead, eat. Everything's ordered. Don't worry about ordering anything." And knowing that
I got it. I'll start it over. You have it or I have it? You have it. Okay. It's an incredible story from Sharp.
I was at the restaurant and just going and saying hi to everybody. And I saw that everything was ordered. So they were like, "Oh, go ahead, eat. Everything's ordered. Don't worry about ordering anything." And knowing that I'm allergic to peanuts, I decided to eat dumplings or pick the steamed dumplings because the fact that they're steamed, they're not. There's no peanut sauce. It's not fried in peanut oil. My last memory of the night was we took a group picture. And then after that, I don't remember anything else.
When I first heard about this patient, I was actually just coming in to start a shift at 10 p.m. I was taking over for the doctor who was going off, and he said, "Hold everything. We got a sick patient coming in. Let's get ready for this, and then I'll tell you about everything else that's been going on." So he said, "It's a bad peanut allergy. That's all I really know, and this guy's unresponsive. He's not breathing on his own anymore."
When a patient's this sick, there's no time to waste. He had already received adrenaline. He had received the mechanical ventilator. He'd received paralytics and was having everything that we could possibly do to try to help him breathe. And unfortunately, it wasn't working.
Right there, fill me up. On a venous, it's not as important because you don't need to.
ECMO functions in such a way that you take blood out of the body, you run it through a complicated system with a filter and with a pump to remove the CO2, the carbon dioxide from the hemoglobin, and to replace it with fresh oxygen that'll bind to the hemoglobin, and then it goes back into the patient.
You put a needle in, you get venous blood back, you slide a wire through that. That's going to be your track to slide your catheter over, but it needs a bunch of serial dilations, and so he was using these just gigantic dilators to create this huge hole for this massive catheter to go into this guy's body.
My first memory is waking up and just looking around and wondering what happened. I had something in my neck. I noticed that. So I started touching it. I was like, "What is this?" And then the nurses came in, and then Dr. Shaw came in, started explaining everything to me.
When I returned back to the hospital about 2 days later, I came in and met Conrad for the first time. He was, at that point, still on the mechanical ventilator, but he was awake, he was interactive, he was communicating, he was writing notes, and it was the most joyous feeling you can possibly imagine to see this young man who had been so close to death, now awake, alert, and able to enjoy his family.
And to see him basically walk out and be a part of his family and be able to talk and walk and interact and basically be the same guy he was before he came in, it's just so exciting, and it's really what you live for in emergency medicine.
Now I feel like I have two birthdays. My birthday when I was born and my birthday when I woke up in the hospital.
So, a couple of things. One, there's no filter.
Yeah.
Okay? There's no filter. The system really isn't that terribly complicated.
It's not.
The cannulas, though large, aren't quite really massive. but
I think that depends on who you ask. You know, if somebody said you want to start an IV and you have a 24 French cannula. That's a big IV.
Yeah, this is true.
Garden
but
hose.
it's just perspective of those who work in our world versus those that work in that world, and the way they describe these things. But anyway, the filter is an oxygenator for, those of you who may not know that, but I think everybody does. But, okay, so, and this is a debate that's been going on for a very long time. What is the survival of patients on ECMO? And it's a real problem because there are people who believe that in fact, I've been told this by intensive care medicine physicians, no one ever lives on ECMO, and unless they didn't need it. And then I've also been told by others, the complete opposite, that people would live a lot more on ECMO if people weren't so afraid of putting it in sooner rather than later. And there's a delicate balance that occurs, and the risk of criticism and the risk of death are so interconnected on this seesaw. And it's a tough one, but hopefully we can address some of that. So CRRT trial came to be for VV to discuss the efficacy and economic assessment of conventional ventilatory support versus ECMO. It was a multi-center randomized controlled trial published in Lancet. The second trial that we're going to look at is the EOLIA, which is, and none of the description of what it is really matches the name of the trial. So I've never figured out how they name these things. I guess they just wanted it to sound good and they couldn't come up with an acronym. But this was published in the New England Journal of Medicine. So let's look at CRRT first. The clinical question is extracorporeal membrane oxygenation, also known as ECMO, a safe, efficient, and cost-effective treatment compared with conventional ventilation for the management of patients that have severe adult respiratory failure, ARDS, or whatever the case may be? It's a randomized controlled trial, 24 of the patients, and there was a total of 108, 200, I think it was 240 total that were ended up randomized, or 180 were obviously selected. Randomized to ECMO, never received the treatment. So that's important to know. 5 patients died either before or during the transfer, and the remaining 17 patients continued with conventional ventilation. Non-blinded to clinicians, but researchers were blinded at up to 6-month follow-up. So very important to understand that this trial was a lot more about transfer of patients to an ECMO center than it was actually about ECMO. And if they didn't transfer, then they got the conventional ventilatory support. It was based in the UK, 92 conventional tertiary ICUs. Glenfield Hospital was the only center where ECMO treatment took place. So that was the ECMO center. So there's 92 hospitals with 11 of them referral hospitals, but only one was an ECMO center. The inclusion, severe but potentially reversible respiratory failure based on the things that you see, the Murray score, the PaO2, FiO2 ratio, PEEP, and so forth, 18 to 65 years of age. Exclusion, peak inspiratory pressures greater than 30 and or a required FiO2 of greater than 80% for more than 7 days. And they excluded them because with an inspiratory peak pressure of over 30 or greater, and that much of concentration of inspired oxygen, after 7 days, the barotrauma and the corrosive properties to the alveoli of that level of oxygen is going to be irreversible. Mm-hmm. And so here, when we see patients that can put on VV ECMO, who they've been whipping the lungs for the past 10 days, mm-hmm. and now out of desperation say, let's put the patient on ECMO, we go right back to that original mm-hmm. thing of the Mr. Barnett who had the arsenic poisoning. Well, they were going to die anyway. Mm-hmm. And that's the problem. Mm-hmm. Interventions, transfer to the ECMO specialist center and consideration for ECMO treatment. All patients randomized for consideration of ECMO were transferred to Glenfield's own specialist retrieval team by their team. No patient was ever transferred on ECMO. If patients were stable, a standard protocol was used, and that describes it there. If patient did not respond within 12 hours, they received cannulation and ECMO according to published institutional guidelines. So if they randomized them to ECMO, they got sent to the ECMO center, but then in the ECMO center, they optimized the ventilation, and at 12 hours, if they didn't respond, then the decision was made to put them on ECMO. Non-responders included patients who had a greater than 90% FiO2 to achieve, and I find this odd, but a pulse ox saturation of 90%. I don't know that I'm really that comfortable with that, only because I've seen a lot of pulse oxes, and the pulse ox had to be on a peripheral digit. So in order to be included in this study, I'm not that comfortable with that, but that was their protocol. And or respiratory or metabolic acidosis of a pH less than 7.2, or were hemodynamically unstable. So those were, if you were a non-responder and you were going to be put on ECMO, that was a done. Veno-venous was the mode, using percutaneous cannulation with, I'm assuming, an Avalon. Servo-controlled roller pumps, not a centrifugal pump, which I found very interesting. And the ECMO was continued until lung recovery or apparent irreversible multi-organ failure had ensued. The outcome, primary outcome, was death or severe disability, which included, or was defined rather, as confinement to bed and ability to wash and dress alone at 6 months after their randomization. In the ECMO group, 17 of the 85 patients that arrived at Glenfield continued to receive conventional ventilation rather than ECMO, and 82% or 14 of those patients survived without severe disability. So taking the patient from their outside community hospital, sending them to the ECMO center, optimizing their ventilator with experienced people, meant that patient survived without severe disability for 6 months, certainly, but never had to be put on ECMO. So now we start thinking and talking about, do the pulmonologists at whatever hospital X who want to do ECMO really understand how to optimize their ventilator? Are they as good at that as perhaps some others may be at ECMO? How many patients, and I think that's really the issue, is do they know how to optimize the ventilator and the patient doesn't need ECMO and can get through without it? Or do they not know how to do that and the patients are getting ECMO that may not have needed it, and that's that subset, that cohort of patients who they say they would have done fine without ECMO? Mm-hmm. It all depends on who's saying that. I think that matters. Let's see. Okay, moving on. So the conclusions of the authors of SESAR are that the study supports ECMO as a valid treatment option for the management of patients with severe respiratory failure. However, it does not show that ECMO is better than conventional ventilation. With incomplete follow-up data in nearly half of the patients, and this is very important, 24% of the patients in the ECMO group not actually receiving ECMO, we are left with insufficient evidence as to whether ECMO is better or worse than standard ventilation. Standard ARDSNet ventilation, protocolized ARDSNet ventilation in adults with patients with severe respiratory failure. The study, however, does highlight the importance of involving specialist units, effective lung protective ventilation, and ECMO as an option in refractory respiratory failure. In the EOLIA trial, the question is in patients with severe ARDS, does the early initiation of extracorporeal membrane oxygenation compared to standard care improve mortality at day 60? That's their central question. So here's their background. Severe ARDS continues to have high mortality despite improvements in mechanical ventilation and rescue therapies. You can read all of this. We all know this. Then they talk a little bit about the SESAR trial, and it remains unclear if ECMO improves outcomes compared to standard treatments, including protective lung ventilation, proning, and recruit maneuvers. So that's the background, and the central question was survival at 60 days. It is a prospective, multi-center, randomized controlled trial. They used predominantly Maquet, but they disclaim or claim that they were not involved in the trial design, data analysis, or interpretation. That's significant, I think, to state that. Target sample size was 331 patients. They had a defined stopping rule, which was safety, efficacy, or futility. 64 centers, international, though predominantly in France. And I think the French are really advancing on the ECMO front. I think they're really making a major push, especially with that mobile ECMO unit that they have. And well, you know, Matt was on here a couple of last month, Matt Warhoover, and he had some data out of their programs. And I'll tell you what, you know, their survival for VA ECMO for patients that have sudden cardiac death was significantly better with those mobile units than standard CPR. So, you know, until putting the ECMO in when they got to the hospital, it seems to be making a difference. You know, I don't know that we're going to be able to do it here, or if we can, where. But you know, France is a much smaller country, but you know, their outcomes are better. Okay. Inclusion criteria, ARDS as described by the American European Consensus Conference definition, and we all know what the definition of ARDS is. Exclusion, less than 18 years old. Mechanical ventilation, greater than 7 days. So here we are again. They're excluding anyone on mechanical ventilation for greater than 7 days. However, you know this, you know this, and you may not know this because you probably a little more, where you are, you might not have that same experience, but we certainly do. 10 days, 9 days. And everybody wonders why our outcomes or why that patient didn't make it. And they were young and survivable, in my opinion.
No, I agree with you on that. It really is just depending on whatever your interpretation of ventilation is. But sometimes I think they're going to turn the corner. I think they're going to turn the corner. Or, you know, today, you know, the blood gases look better, ventilation looks a little bit better, and then it goes backwards. And so I do see that a lot. You know, I'm in a heart failure unit, but with that is lung transplants in those pulmonary patients. And to answer that, basically, I don't know if it's just go in one direction or the other. You can't necessarily say that because there's so much strategy involved in these pulmonary patients.
Yeah, I think that's a fair assessment. I think you know, taking the opposite side of my argument, but I think that though I agree with you in large part, I think that that I don't necessarily believe in centralization as a thing, but I do feel that we are over competitive in hospitals, and that especially when they're in close proximity to each other. And I do think that in order to manage these patients that have severe respiratory dysfunction of whatever sort, you have to see enough of it to really be good at it. And I do think that we need to consider, I don't believe in single payer healthcare. I'm not a socialist by any stretch of the imagination, but I do think that the more you do of something, and I think it's commonsensical, the more you do of anything, theoretically, and I think mostly, you are better at it. And so I think that these really highly critical patients like this need to be assessed at any hospital in any area, and one of them be selected as the place where they go.
Well,
Makes more sense.
No, you're absolutely right. But a part of that is I think physicians in general, because they're at the end of the day, they're the ones that make the decisions. I think if you just understand your limitations, and that's not saying you're a bad physician or you're a good physician. What that means is, you know what? I've had a run of these type of patients. Let me pass it on. It doesn't mean that this other physician is better than me, but if that's what they deal with all day, every day, like you're saying, then send them there. I don't necessarily think that your hospital is any less than mine. It's just what you see in volume. So, you know, we see heart failure patients, but you see your standard patients that are healthy. And so your ventilator strategy works on most of these patients. You see it in your ICU. Just because they're not a lung patient, you have these strategies that work that you get patients, in the hospital out all day long. It's just when you have that bad one, that's when you're like, where did I go wrong? When should I have made that decision to transfer them? Not because they're better, but because they have a better plan than we do.
Well, yes, I mean that's true too. But again, that kind of goes to the central point of, first of all, your issue of, or your point that about the physicians, and I think this is with really almost any high level advanced practice clinicians like all of us at this table, or physicians, frequently wrong, never in doubt. And I don't think that that's helpful. I think that you have to. It's very hard for them to know their limitations because, again, you just don't know your limitations. That's not what we're trained to do. That's not how we're built. That's not how we're supposed to think. And those are pressures put on us by administrators, by society, by ourselves, each other, and everything else. But there's not any one place, for example, in a city like Houston, in the med center, that can manage, let's just say it's you. There's only so many beds you have.
Correct.
You can only make those buildings so big. Right. So in a community like this, you need more than one center, but you don't need every hospital in a 40-mile radius, and there's a lot of them, or 50-mile radius even, and there's a lot of them to just go sticking people on ECMO. Now you maybe put it in, get it initiated, but there's got to be a system. You're coming to get this patient like right now. Make the decision over the phone, look at the parameters, make whatever adjustments. Somebody makes that call, because look at what's happening with the reimbursement on it. Why do you think that's happened? It's happened because of it's just being thrown in. And there's nothing wrong with just throwing it in if that's the right thing to do, and mostly it is. But you have to manage the patient.
You have to have a plan.
Right. ECMO is not curative.
Right.
It buys you time to fix the problem, and it requires a lot of nuance associated with your therapeutic modality. You need to have ECMO. You need to have CRRT. You should have, I think, hemoadsorption. I think you should have a lot. I mean, there's a lot of components to this. Infectious disease, you got to treat the problem, the antibiotics, what the original problem, if that's what it is. It's not as simple as I put the ECMO in and the patient is going to now miraculously get better on his own because the ECMO's in.
You need an ECMO management team from all perspectives.
And then resource utilization, being able to accommodate changes like that. We talked about that last night with staffing models. There's a lot to it. It's a complicated subject and a complicated topic. And if you do it well, it can be certainly at worst cost neutral for a hospital. There's a possibility that hospitals can actually generate some meaningful profit from it. Nobody's going to get rich from it, but certainly make it cost neutral, and make your hospital stand out if you're really good at it. But if you do it wrong, it's horribly expensive.
That's correct.
Okay. I'm sorry, go back on my thing here. Okay, so the exclusion criteria are these things here: pregnancy, grossly morbid obesity, any kind of long-term chronic problem, and that a cardiac failure resulting in VA ECMO, where you had to convert, cancer, all of these various things. So out of 10,015 patients that were assessed for eligibility, they actually randomized 249 of these patients. And you'll notice, again, the mean age is 51 to 54 years old, which is really the kind of sweet spot for when we see patients that need it and patients that should be highly viable. And also very interesting is look at the percentage of patients were in there for septic shock, 65 to 67%. So a very significant rate. And bacterial pneumonia was the commonest diagnosis. Again, not something unusual. That is usually what we see in the VA ECMO world. Primary outcome was no statistical difference in mortality at day 60 for the ECMO group or the control group, though it was 44 out of 124 versus 57 out of 125, 35 to 46%. It did not achieve statistical significance, which I found very interesting. It seems anecdotally that seems like a better number to me, but it doesn't meet the statistical test. So your relative risk of dying was 76% with a 95% confidence interval. There were some secondary outcomes. Crossover to ECMO, interestingly enough, occurred 35 of the 125 patients of the control group. And I don't think they did such a great job at readjusting the numbers on that. 60-day mortality was higher in the crossover patients, as one would expect, than the rest of the controls, because again, you took a patient who was failing traditional therapy and said they've gotten so bad we cannot handle them anymore. Let's now put them on ECMO. How much did that contribute to this? I think a lot. Adverse events compared to control patients. ECMO patients had more thrombocytopenia, not surprising. More bleeding events, but they had less ischemic strokes. Again, not surprising. You have perfusion, you have oxygenation, so you're not going to have an ischemic stroke. The author's conclusions that for ECMO, for severe ARDS, showed no significant benefit of mortality at day 60 as compared with a strategy of conventional mechanical ventilation, which included crossover to ECMO used by 28% of the patients in the control group. However, the bottom line is that the study trial provides inclusive support for the benefit of ECMO in severe ARDS. The early initiation of ECMO did not improve 60-day mortality with an absolute risk ratio of 20% compared to standard care in patients. However, the data also suggests a possible clinical benefit from ECMO over standard care, especially if used early rather than late. Standard therapy included proning, neuromuscular blockade, and they had a high rate of failure requiring rescue with ECMO. So proning alone was not considered very positive in this setting.
We got to think about what you're doing, though. You know, if somebody doesn't understand that, you're laying a patient, you're moving a patient with these garden hoses coming out of their neck or their groin. Very difficult. So there's a high risk of other complications with that. So
acute decannulation. Acute unintended decannulation.
Correct. Amongst other things. Exactly. Plus infection, because, you know, I mean, you see these patients, you know, patients have all functions, right? So when they're dirty, they're soiled or whatever. Now they're moving, positioning, and, you know, sliding up and down the bed. You're just putting them at more risk for infection, plus pressure ulcers, everything else. I mean, to me, the proning, I don't know that that necessarily outweighs all the other negative effects with it.
Thank you. But I will tell you this, is that although I do think there is a downside to proning, but the patients that I've seen on ECMO that we have also proned have definitely benefited from it. From a purely pulmonary perspective, their oxygenation gets better, the vent pressures go down, everything looks better. And so one of the reasons why I really, for VV ECMO, dislike groin cannulation is when we're not going to prone the patient and you see them, especially when they're heavy and they're lying flat and they're, you know, they have a little short chest but a big barrel belly, and it's just shoving all that pressure up on the diaphragm. You see these really high peak pressures on the ventilator. And everybody's struggling. And I just will set them up, even put them in a reverse Trendelenburg and sit them up as much as I can to drop all of that and take the pressure away. And you see the peak pressures on the ventilator come way down. You recruit some additional lung. You can sort of turn the FiO2 down. It just looks better. They get better. So I do think proning works, but I do think that there is an issue with safety and with increased risk of infection. So it does have a dark side, but they do get better from a lung perspective, I don't think.
Now, did you mention the weight thing? I noticed in their study how you just see nobody was overweight.
Right.
Yeah.
So I think that's kind of a big gray area. That's great for the study because it shows he's on somewhat healthy patients. But on the other hand, that's not our typical patient population.
Right.
I mean, VA or I mean, Houston, US, wherever you want to see it. But at the end of the day, their weight is really what's contributing to these conditions. Yeah, you might have an acute lung condition, whether it be asthma or a PE or something. But at the end of the day, these heart failure patients, these guys they're overweight. They have multiple comorbidities.
Yeah.
And so that weight's a factor. So I would like to see the same study with patients with a higher BMI, because that's what we see.
Yeah.
I'm not saying everybody needs to have a large panis, but you get the point, because that plays a factor in our position.
It does. And we're going to come right back to that. Throw my last slide up. Let me just tell you this. 3 keys to success for ECMO: selection, selection, and selection. Also, early decision, early utilization. Understanding that when you put it in early, you see improved outcomes, you're going to be criticized. So if you put an unrecoverable patient on ECMO, the outcome will certainly be poor. If you believe no one survives on ECMO, you'd be wrong. If you cave to the pressure of criticism vis-a-vis the patient didn't really need it, you will wait until it's too late. And the patient won't do well, because now you've lost your window of opportunity. And use the published guidelines and develop your own inclusion, exclusion criteria and follow it. And this is the hardest thing to say of all, is you got to know when it's time to stop. Because the pain the families go through is worse. The patient feels nothing at this point. The family is going through a lot of pain. And sometimes it's, hard, but it's, it's sort of obvious at times. I know none of us want to say that, but it's just the way it is. We can keep this going for another 3 or 4 days, but it's not, the end is the end when there's refractory acidosis. You know what I'm talking about.
Right.
It's obvious. I know sometimes, I've had curveballs thrown at me, and I know
Absolutely.
that's tough, but we got to figure it out. But getting to your point that I wanted to sort of expand on is, yes, those were the patients they were doing it on, but don't we sort of need to start thinking that way here too? Don't we need to say, look, you have to have some personal responsibility. His BMI is X. He is not a candidate, because the outcomes with those people are so poor. Whereas here's not a picture of health, but not morbidly obese, maybe somebody like me, or maybe a little worse. And they just drop dead for no reason. That's a really salvageable case. But when they're 380 pounds and 5'7", they're not going to make it.
See, on that part, it sounds great, but I have physically experienced more than one 400-pound patient comes back in and says thank you.
And there you go.
On multiple occasions.
Yeah, it happens. You're right. It happens. And nobody has a crystal ball, right?
No, I think at best bet, we need to have more structure, if I had to guess it with anything, because we have so many specialties, and it's like, man, that's great. Heme path, manage that coagulation, pulmonary, manage that ventilation, surgical. We can manage cannulation techniques, strategies, position. The same thing with cardiology. But at the end of the day, because there's so many things, so many specialties, we don't have a strict guideline that would push us in the right direction. Because this 400-pound patient made it today, that's great, and we did the right thing, and we did what we wanted to do, and it turned out that way. That also sets us back 10 patients. Because of that one patient, we do the same thing for the next 10 patients, and it doesn't work. But we're like, remember, Mr. Smith, it worked for him. That's why we're still doing it.
Yeah. And you know what? And that's a valid point. It's like stopping. There was a patient on ECMO, and somebody asked me what I thought. And I said, well, it was the day before Thanksgiving. And I said, well, I think she's not going to be with us by the time the turkey comes out the oven. A week later, she was sitting up and talking to everybody, and I was like, oh my God, I'll never say that again. Oh my God. It happens. But then there's the other ones that I'm like, this patient should just do fine. They don't.
Right.
And that's, I think, what happens. But I think you would agree that when the patient's platelet count is 0 and the white count is 0 and their feet are black and their pH has been 7.1 for the past 3 days, it's time to stop. There are some obvious ones.
I've seen them come back from that as well.
No, you haven't. I don't believe it. No, you're exaggerating. You were dreaming.
No.
You were dreaming on that one. You were dreaming.
No, so
You were dreaming.
that's what you got to ask yourself. And because I had this pulmonary physician, this critical care intensivist, I asked him that. I said, "Hey, man, what are we doing? This patient's old enough where you're like, okay, now what do we do?" At the same time, like, look at the toes, look at the feet. You know the slow process. First it's toes, then it's the feet. Now you have a bilateral amputee for whatever reason, compartment syndrome. But then they come out of it. And so now you're 6 months down the road and you say, hey, what happened? Like, I don't know. I blacked out, 3 months were gone. I have prosthetics, but now I get to go home to my 3 children.
Yeah, and then you get sued for cutting off their feet. But I think that's extremely, extremely, extremely rare. I'm not so sure. I mean, that sounds, I believe you, but
No, but you don't need your hands and your feet. I guess that's what I'm looking at.
I do. I need them.
You need them, but when you
need your hands and feet.
If it's my mom, I'm going to say, you know what? I love my mom. So I can push her in a wheelchair. I can feed her. I can get her support. That's my personal belief. So because of that, we're going to go a little bit further because I have the good support system for her. Everybody else may not agree with that. And so, again, you don't need those things to
I
function.
don't agree with it for me. But that's personal choice, and I
Right.
do understand. I think that's why we should all have advanced directives. I think we should all make
Agree.
clear what our wishes are. Okay, I mean, I think that you start whittling my my limbs off, it's time to quit. Okay, and so that's just how but that's personal. And I think that we all, if you want everything possible done, no matter what, then I think you need to make that clear. And I think we have to start taking more personal responsibility for our health.
No, I agree with
lot
that.
of things.
With the personal, but see, and that falls on the physician, which is something, it's not fair, but it's just a fact because they're the decision maker. And so when that same physician, I asked him, he's like, because it's personal to him. And I said, well, you don't know them. He said, no, but every patient's personal. You know, they're not seeing 500 patients, they're seeing 10 or 20 at a time. And so when they're on ECMO or they're on these devices, you grow to know them. You grow to see the pictures on the wall in there. And so everybody's personal to them. So that's why they look at it this way. This is always somebody's something to them.
And that's fair. I can understand that. I think that's fair. Very good discussion.